It just be silence and crackling microphone sounds from me anyway.
No worries. Well, maybe we'll set up a system of 2 crackles for yes, 1 crackle for no.
Sounds good.
Okay. Okay, so sorry, I cut you off there, Rob. Do you remember
no worries. So, no, it's just going back to the article starts with a fairly strong head of steam and then tapers off, but never actually, like, I know it's a consensus, but the consensus needs to include, like, if I'm in a room full of people who study a subject and there's a whole bunch of question marks on that subject, that consensus needs to include, okay, yeah, we have a lot of question marks, and here's where we're hoping it goes, here's where we think it'll go, and here are the things that are trying to take it there right now. So if I go through, what was that author's name? Really famous sci-fi author, like earlier last century.
Asimov?
Yeah, if I look at the Asimov Summit, thank you. If I watch the Asimov Summit every year, we'll have a panel with string theorists and multiverse theorists all on the same stage, right? The string theorists won't just say, here's our theory and explains this. They'll also have to say, here's our theory, here's our consensus, and we recognize this weakness, which we think can be filled in by these gaps.
Okay.
And so our testing doesn't bring this, but this does yield this. However, we're confident that our testing will also help fill in those gaps from our own methodology. And so that's why you kind of have this big bolus of information that's like, holy crap, there's a lot here. And it kind of trickles down and it gets to testing in Young's modulus. And they went to Young's modulus like 10 times, which is just...
I still don't know what the hell it is.
It's a method for testing viscoelasticity. I think I'm pronouncing that right, viscoelasticity. So Young's modulus is just a way of saying, okay, what's the force required for something to return, like to deform something and have it return back to its original shape. The MES point I mentioned before is the terminus of Young's modulus. So Young's modulus is how much force do we apply for you not to be affected? Minimum essential strain point, MES point, is what's the minimum strain point needed to apply for you to be affected. And in the body, we have to consider that as a dynamic rather than a static feature. So we're not just mechanical. So we have to look at the immune system and the nervous system. So with bone deformation, this is a femur. That's right, this is a femur. If I take a femur and I load it axially and it bends, I've hit minimum essential strain point. It is deformed. And now there is a piezoelectric effect for the nervous system, and then there's those intraosseous cell receptors for the immune system, and they get their signal and they say, shit, that bone needs to be more dense and more strong. And so the Young's modulus for bone would be the amount of force the bone can take without having an effect on it in the end range, or in the end time. The minimum essential strain point is the minimum point needed to cause a change. And then we get to levels of failure point if that minimum essential strain point is challenged over time, enough times without adaptation, or in enough of a bolus at once to cause critical failure beyond immediate adaptation or beyond reasonable adaptation. Like minimum essential strain is thought to be, I think, 10% the force required to break it. So on average, and I could be wrong, it might be half the force, but I think it's a tenth the force. That's a huge range. Yeah. And so they go to that a lot, and that's like the terminus point in the article. Like I said, the one point was the turning point where they're like, okay, we're going to sneak in. By the way, it's fascia. And then the terminus point on the information being pretty reliable was the Young's modulus point. They went to that a bunch of times and said, here, viscoelasticity, viscoelasticity, viscoelasticity. And then, well, yeah, so our testing isn't the greatest, but, I mean, viscoelasticity. And then, okay, our interventions, I mean, let's face it, like one of the last sentences blew my mind. Finally, manual therapy, such as massage, osteopathy, or rolfing, are frequently used to improve fascial tissue regeneration and athletic performance, although their efficacy still remains to be validated. And so,
you like that one too, did you?
Oh yeah, they just squeezed that in there.
I know.
And
and I guess it's that last section where you wanted the most information.
you wanted them to sum it up and give you your ice
Yeah.
cream.
Yeah. So
or even if they're not going to give me ice cream, definitively say, by the way, most of what you're doing is bullshit. Okay, I can for that.
I feel like that would not be the nicest accepted one for a conference.
Yeah. Probably. But
I don't think our feelings should be hurt. You know, again, when you go back to the author affiliation, there are people from biomedical institutes and sports medicine. The only only person that I can see really on there who comes from massage is Robert Sleep. Everybody else has physiotherapy and or sports therapy and or, you know, that kind of affiliation. So yeah, again, we couldn't really expect more from the title because they talk about sports medicine. And again, you know, Rob's beef is legitimate. It doesn't talk about where we're going now with regards to connecting that neurological aspect. And I know that Robert Sleep in some of his online talks does get into that. So perhaps it wasn't included because his voice wasn't as large in this article as it might be if it wasn't an article designed for physiotherapists, sports therapists, et cetera, et cetera.
Mhm.
And that's all I have to say because I got to run because I got to go to work now, guys.
Great.
And I'll read the follow-up or whatever gets left behind on the page. And we'll do it again.
Yeah, absolutely.
Okay.
So,
Bye.
bye, Ken. Nice meeting you.
See you again.
See you.
You can.
so going to Robert Schleip or Sleep, I guess, maybe? I mean,
It's Schleip, actually.
is it Schleip? Okay, that's
Yeah,
how I always pronounced it.
We are hearing you, by the way, and you must be hearing us, Don.
I'm hearing you fine with my crackly mic when I plug it in.
No, you sound perfect.
Yeah, I've unplugged it, but I can't hear you.
Oh.
Oh, Don,
Yes.
your headphones have that little white part. That means there's a microphone on it. Can you turn on the microphone?
Yeah, I tried that, but I think it's knackered. It went through the wash a few times.
Okay. But yeah, with regard to Schleip, with talking about, you know, why don't we see more from him on this? Because he'd be the voice who would contribute to that. He's kind of become overly guru-ish in the last, 6 years? 7 years, something like that? Sorry?
I've never read anything or whatever about him.
Yeah, at one of these last Fascial conferences, he was supposed to speak for like 2 hours or something, or an hour. He went up on stage, he said, "Here's my wife, and this is her new fascial intervention system," and turned it into like a sales pitch. And that was the last I'd heard of people kind of taking his stuff more at face value. He's kind of gotten more and more monetary, less and less researchy, it seems.
Mm.
And so, like, I tend to really, that would probably be a lot of why we wouldn't see him in the consensus being quoted as much as, say, you would have 20 years ago or 15 years ago when he was, I don't know if I would say unbiased because I don't know him at all, but when he was a lot more science-y and a lot less commerce-y, because he kind of turned into a bit of a salesperson for his method. I haven't seen anything from him in a while that was, you know, here's my research and here's what it means. It was, here's my research and this product, you need to buy it. This system is great and it will affect this.
All right.
So it goes back to the whole manual therapy thing. And I mean, we need to include with physio, I know this is geared towards physio and medical practitioners. I mean, I'm still dealing with surgeons who think that manual therapy is going to break down scar tissue. They need someone to get in there and break down that scar tissue after I replace the knee.
Yeah.
And
we kind of want it, don't we?
Sorry, Joe?
Scar tissue there after surgery, don't we?
Well,
got a job.
The idea is to, okay, you know when those anastomoses kind of fade away, the pinkness of the scar tissue? So the idea is that in the first 6 months, the scar tissue is more pink and a bit more friable, but within the after the first month or two, it starts to get more dense and more robust. And then from that, the remainder of that 6 month window is the time that we can intervene the most mechanically with our hands. And then from the next 6 to 24 months, we're looking at tissue adaptation and maturation. And the scar gets more functional and strong. And so during that 24-month overall window, we have our chance to manually intervene and guide the scar as we want it. How much scar tissue, how dense, how supple, etc. We can't really measure that, but we just assume that's what we're doing. And so, like the one surgeon I was talking to, that was his thought. He goes, I want an ART practitioner because they can get in there and break up the scar tissue and leave a functional scar. And I'm like, what about just exercise? Exercise does the same thing. He's like, yeah, but the ART practitioner is breaking it up. Okay.
Right.
You know what? Sorry to interrupt here. Just something to what you said, Rob. What really bothers me is these different techniques that have been trademarked. ART, myofascial release, and then the physicians and surgeons get a hold of them, or they read that little blurb on what it's supposed to do, and they're going, well, we're only going to refer to someone who does ART, whereas most massage therapists will do some format of ART. I know this is a little off topic of what we're going on, but this is my little pet peeve with surgeons and other physicians who think, oh, we got to go ART or myofascial release or something. And I understand that, you know, learning these techniques, I think it's great because it gives you a bit more practice in the technique, but I don't think it's also the be all and end all by sending them. So, but that's my little rant. So we'll go back to what we were discussing.
Well, no, actually, that actually ties in really well with this. I wish Petz was here this morning. Dan Petz, he's an ART practitioner, and he was telling you the guy who founded ART and his thoughts on our current understanding of fascial plasticity and our odds of actually breaking down adhesions, because the research we have out there is pretty strongly against it. Not to say it's impossible, it's just pretty darn unlikely. And I'm paraphrasing here, but apparently the guy who started the whole, like the founder of ART, one of his colleagues was like, okay, we got to talk about the fact that the research is really not on our side with regard to breaking down connective tissues. And he said, no, I don't want to hear it. It's all scar tissue. We're breaking it down. I'm sticking to that. And he's just so invested because his whole empire, and I mean, ART is your I have more money than sense course. So, I mean, good marketing, but otherwise.
Yeah.
And so his whole empire, and he's got to be a multi-millionaire at this point, is based on something that isn't demonstrable and is increasingly less likely as we understand more.
Yeah. So just going to something in this article about not demonstratable or not studied enough, just back to interventions for fascial tissue, that last paragraph.
Okay.
The clinic that I'm working in does a lot of shockwave therapy. Okay. So it says moderate evidence exists on the value of shockwave therapy. So of course my clients come in, they're going, oh, I have plantar fasciitis or, you know, lateral epicondylitis, like any of those golfers, you know, I was told shockwave therapy will cure it, you know, 3 to 5 treatments. And I'm going, well, it'll be a start, right? And you're trying to educate your clients and that it has to do more with not just the actual manual treatment, but all the home care they have to do, the self-care. But the advertising and it's sort of like this article. It's if you can get the wow words out there, people are seeming to buy into it, even though it doesn't have anything behind it that says, you know, yes, this is gonna the issue.
I wonder if that is the problem of the magic bullet, right? So nobody wants to put their own effort in, or very few people do, because whatever, their lives are full or they're lazy, both, who knows. And so, I mean, if you think about it, you have something going on in your body that's interrupting your ability to continue with whatever your normal lifestyle is. And somebody says to you, oh yeah, just hop on the table for like 30 minutes a couple times a week for 2-3 weeks and we'll get you right as rain. You don't got to do anything. Just give me some money.
Yeah.
A lot of people will hop on that because they don't want to have to do anything. Meanwhile, if they took, like, let's say the normal treatment plan for shockwave therapy is to come in twice a week for 30 minutes. You could take one of those appointments and just do exercise and probably end up with the same result, but you have to invest yourself into it more, right? Or even a better result than just doing the passive care.
I don't know what the intervention, there's got to be a term for this. I don't know what it is. I'll just say intervention ratio. Like, I don't know how shockwave compares, if we compare it to just placebo, compare to exercise-based or to a control. So I'm not sure where it stands up like that, but yeah, I think you bring up a really good point there. There was something about tendon stiffness softening in here.
Oh yeah, I think in it talks about that in the foam rolling and probably in the mechanobiology of fascial tissues, effects, and exercise and disease.
Yeah.
So that's like the column before the tiny segment on intervention.
Holy crap, you're right. The intervention section is really tiny, isn't it?
Yeah.
Literally one paragraph.
It's one paragraph.
I didn't think about that. Holy crap. So
if I may come back to something that's also going back to some of what we talked about earlier under the molecular adaptation. So page 2, column 1, molecular adaptation of fascial tissues. I found that there is actually some really interesting stuff here that could pertain particularly to people, even RMTs, who are working in sports medicine or sporting environments like rehab, working with let's say a sports team or whatever. I thought that there was some interesting stuff, especially with regards to how sex or sex hormone activity impacts how your fascial tissues work, as well as some stuff about the communication, which sort of ties into what we were talking about before, that there's molecular crosstalk between the extracellular matrix and and the actual cells that are in the extracellular matrix, and how this cellular crosstalk can alter what's happening in the cells as well as what's happening in the ECM. And the thing, and this is where it comes back to what Rob was saying about the nervous system. The thing about this is making you wonder what is triggering this communication to happen, right? Is there, that's the question. What is actually triggering that communication to happen? Because the ECM, I don't see it as a living structure. It's the chemical soup that the living structure is in. So is the ECM actually generating these communications? Is the ECM actually receiving these communications and responding? Or is it simply you add this chemical to this other thing and you get a different chemical soup out of it. But that was a little rambly.
So basically, is the extracellular matrix acting as just kind of a medium for things to travel through?
Yeah.
Or what we're trying to say is like the matrix itself outside of the cells is alive.
Yes, yes. And you know, because it seems as though they are saying the ECM itself is producing its own communicative messages to you know, have this crosstalk with the cells that are within it. I was very skeptical of that statement. And, you know, I would have to look at the other references that they have for this. But yeah, that was a wondering I had was, is the ECM doing the talking, or is it simply transmitting this communication from another system?
I don't know. I'm not sure what they would think. Like, I know what I think.
Mm-hmm.
I know my belief on that, but I don't even know if my belief is backed by evidence and everything. My belief is that, yeah, it's inert tissue.
Mm-hmm.
But, I mean, it certainly doesn't exhibit the characteristics of life. Irritability, creation of waste. Like, the ECM doesn't make its own waste products on its own.
Mm.
So I don't know. I'm not sure what they would say if they're trying to say that it, in and of itself, the ECM is. Well, they are saying the ECM is part of the fascial system.
Yeah.
But I mean, where do you draw the line if I'm talking about the digestive system? Then am I going to say that the adipose tissue around the organs is part of the digestive system?
Mm.
Because that seems like that would be a reasonable extension if I compare similarly,
Mm-hmm.
or that the, oh God, I don't know. I got nothing. That's the one I got.
Yeah. Well, and the thing that I'm leaning towards in that is I feel like I would have a really hard time saying that that's true or correct. That I could see the ECM being a conduit in
Yeah.
the satellite is, but the satellite itself doesn't generate. Well, I don't know. Maybe they do. I don't know anything about satellites, but you know, if I have a radio and I don't turn it on, it's not going to be sending out a signal that is of any use, right? And I see the ECM being the same kind of way. If there isn't something else putting a communicative message in there, then it's not creating that itself. It's not manifesting this communication itself. It's transmitting it or conducting it to the end target cell.
Mm-hmm.
So I maybe I actually disagree with what that statement says in this article, which feels very bold for my uneducated ass.
Well, like I was saying before, like they are very much speaking to their bias here.
Mm.
It's just that unfortunately they're leaving out everything else. If I want to speak to an uneducated crowd, I will just speak to my bias. If I want to speak to an educated crowd, I will mention the contraries to my bias to make sure I've taken them into account.
Mm. Okay.
So, but again, this is a consensus thing, right? So I guess that wouldn't be important, but I still think it should be.
So something else that I mentioned was on page 3 at the top of the column, new paragraph. They discuss fascial tissues such as tendons in acute and chronic loading stimulates collagen remodeling. And they go on to discuss how this is different between male bodies and female bodies.
Mm-hmm.
And estrogens may play an important role in regulating ECM remodeling. So the effects of estrogens on collagen synthesis appear to differ between rest and response to exercise. while estrogen replacement in elderly postmenopausal women impairs collagen synthesis in response to exercise, estrogen has a stimulating effect on collagen synthesis at rest. Oral contraceptives, on the other hand, have an overall depressing effect on collagen synthesis. So I don't work with athletes, really. They may show up in my treatment room, but they're not really the group that I tend to target. But I would think that for an RMT who maybe is participating in a sports rehabilitative clinic, and if they have a tendency to focus on female athletes, this would be something really important to maybe the type of work that they do and how they participate in the coaching environment. If we know that estrogen will have a different effect depending on what they're doing with their body at the time. So a female body at rest will have a different response to building collagen versus a female body in activity. And then also considering female hormonal cycles and how the timing of exercise and rest may have to be a factor in developing training plans, and including when to rest, and how that rest component, like I kind of see for a lot of massage therapists, rest is a big function that we perform. We facilitate that resting state. And when a person is at rest is generally when their bodies are focusing on homeostatic balance. So this was something that I thought was interesting. And also I wanted to highlight the fact that, oh my God, they talked about women in science and how maybe we should be. So just wanted to like underline that a wee bit because that was exciting for me as someone who possesses a female body.
Well, seeing this one too, it's one short paragraph, like 4 or 5 lines.
I know.
You'd have to look at all the other articles that are being, and research papers that are being referred to in this.
Yeah.
But again, they're talking about the estrogen, but a lot of women now are on some sort of hormone therapy, whether it's the pill. Yep. Very few are on a natural progression.
Yes.
Right. So again, it's nice that they put that in there, but it's such a short statement for such a large topic that you can't really get enough out of it.
No.
To make an educated assumption of how you're going to progress if you do have a female that's coming in. And these days also, women aren't, and men too, but to this paragraph, women aren't resting when they need to rest.
No, people.
Okay, we are taking on the same habits as men have had over the last hundreds of years. And it's affecting us differently. If you look at how heart attacks affect women, very little research is done on women and heart attacks and the symptoms they have compared to men. So it's a nice statement to have in there, but it's so small that you need to look for more information before
definitely
you can actually make a decision on how you're going to react to that.
And I think that so the purpose of this talk is skills development for us, right? So one of the things that is a skill when using and interacting with research is being able to identify, one, does this paper actually have relevance to my practice? And 2, I think maybe what you're pointing out, Renata, is can I actually just make decisions based on this one document? No, we can't, right? So this, this is where the rabbit hole of research starts, right? So if we really wanted to learn more about this specific subject, how does collagen formation, and repair happen in women, we would be looking up articles 10 through 14 and reading those specifically to gain more information, and then probably looking for the references in those articles and seeing where they go as well, right?
Yeah.
But yeah, I think you're right. And the question that I sort of pulled out of that was, what considerations would need to be made when working with female athletes who are using some sort of hormone replacement? Another question to that could be, how does this affect people who are maybe in a gender transition? Probably going to have a pretty big impact, especially if they're athletes. And we are seeing a lot more athletes who are transitioning from one gender to another using hormone therapy. So how does that play into their hypertrophy, growth, as well as rest and recovery? Which is just a question that I don't expect any of us to answer, but a wondering that one would need to have when working in athletic populations, especially if you're encountering transgendered athletes. Wow, everybody got quiet.
Well, I think you mentioned the last one, so you brought the last point. I think I was waiting for you to say something else or pass off the mic or something.
No, it can go. I mean, I could continue with other stuff, but I don't want to hog the thing.
I just wasn't sure if you were done speaking. I didn't want to interrupt because this is one I don't have good information to contribute, except for like gait retraining on people confirming their gender and stuff like that, right? But, well, men and women walk differently. When you have someone who's lived their life as a male transitioning to female or confirming to female, you have to help retrain them for their gait. Things like that. Like, we don't have to, but it's something that behooves them to do to feel like them. If someone who identifies as a woman still walks very much like a man, that can be actually bad for their mental and emotional health, their sense of self, things like that. Really? And so some physios will do mobility coaching on that. Hell, I've done mobility coaching on that, and I'm not a physio. But that's about the extent of what I can contribute to, so that's not a lot. I literally walked away from your statements. I was like, okay. Like, I grabbed my phone. I was like, effective oral contraceptives on exercise recovery in women, and made a note to look up tomorrow after some appointments I have.
Oh, right on.
But yeah, so couple things here. God damn, my writing's awful. Myofascial force transmission, the locomotor system, availability point towards the existence of one remote. Okay, remote exercise effects and stiffness. We're going to page 3 out of 9. There's a really annoying part here that... Which,
is this under the myofascial force transmission?
Yeah, bottom right corner, page 3 of 9, last sentence or two.
Oh, I have a little bracket and evidence question mark is in a what the fuck?
Yeah, and so I basically have similar. Fine, screw you too, Kat. It has been showing that stretching of the lower limb increases range of motion of the cervical spine. Yeah, we know that. There's a stupid human trick I do with my patients, and I used to attribute it to potentially decreased overall sympathetic nervous response, where I'll have someone lay on the table, I'll stretch their hamstring, and we'll goniometer, we'll measure, okay, where do you feel a stretch? At 60 degrees? Okay, perfect. and then I'll take their shoulder and I'll override their rotator cuff muscles. So I'll have them resist me, and I'll push in 10 times. And I'll re-stretch the hamstring muscle, and voila, we're at 90 degrees. Oh my God, amazing. I watched this video recently by Andrea Spina. He's a chiropractor, actually, who's kind of close to Jen and I. He works in Vaughan near us. And he's the guy who came up with the functional anatomy systems series. So functional anatomy and palpation, functional range release, all that stuff. And his stuff is pretty darn good. And one of his talks, he talks about fooling the nervous system, and talks about like he does the exact same example I do. He has someone on this table and he has them stretch their hamstring, and he goes, okay, now watch out how far I go if I have him pushing this big toe 6 times, and the stretch is so much better, right? And finally he does it remotely. He goes, okay, so I'm going to stretch this guy, but first I want you over there to stretch your hamstring. And now when I stretch this guy, oh my God, look, it's better. Why? I didn't even touch him. What about this side? Oh my God. And he basically takes it back to, it's easy to fool the nervous system. So he literally does a test once on someone and stretches them and checks, oh, you got to 55 degrees. And then he goes to someone across the room and says, okay, I want you to stretch your hamstrings for 30 seconds. And the guy stands there and stretches. And he re-stretches the original person and goes to like 80 degrees. He goes, what did I just do? I mean, was it magic? Was it voodoo? No, we fooled his nervous system. And statements like this, stretching the hamstring demonstrate range of motion increase in the cervical spine. Well, duh. I used to teach that all the time in my classes on treatments classes. And it's a nervous system hack, right? But we're talking about this. They're just like, and look, if you stretch the hamstring, it affects the fascial system, and voila, the cervical spine gets benefit.
Yeah. Well, and the sentence that follows immediately after that is, because the involved body regions are connected by a myofascial chain, myofascial force transition might be the cause of the observation. So it's really an educated guess. And this I felt was like a really big neon sign. Look at our bias. Woo! Right?
Yeah, and it's like, this is one that in something that's a consensus statement, that we know is not necessarily the case. Like, we are really confident in saying that this is neuromodulated, not a fascial thing. The fascial component might be there, but we have a really obvious elephant in the room, and I can demonstrate it verbally. Okay, we're not talking force transmission anymore. I can literally say, I'm going to stretch your leg and hold it, and I'm going to pull it to where you feel a stretch, or I'm going to do it with your arm or your neck or whatever. And I want you to visualize chewing bubble gum, and all of a sudden I can stretch you further. I mean, what, did you imagine a fascial system and it pulled on your real one? No, this is neuromodulating. And that was like that statement, that whole overall statement, but that statement especially about range of motion of the C-spine with lower limb stretching, etc., and attributing it to some mechanical property. Really, again, 5 years ago, Robbie would have been like, oh yeah, that makes total sense. It's all connected. Now Robbie is like, you son of a bitch. But
it's funny because it's almost like they set that whole up with the section previous regarding transmission. And they're saying that muscles don't just pull on bones, they pull on the fascia as well. It's sort of like, duh, they're attached. Like, of course it's going to have some transmission of the force. Is that important? Maybe, probably not. I think say something somewhere about as fascia deforms or adapts to whatever, it can have a change in that force transmission. Okay, that might be a little bit more relevant. But then that leads us to think about the intervention section. As a massage therapist, probably not very relevant to me. I may not be able to do anything about that.
Well, that, to me, that actually, wait, are you talking the force transmission one or the effects we just talked about?
Well, kind of both, because it's almost as though they're setting up their bias by saying, because muscles can pull on fascia, therefore, when we stretch this body part all the hell at the other end of the body over here, we can have a big change over here. And therefore, it's muscle force transmission through the fascia, which if you set your statement up like that, okay, sure. But when we take into account all the rest of the systems in the body, particularly the nervous system, then we kind of go, well, hold up a second. Maybe that's not quite exactly how this is working.
And the how and the, oh God, I'm going to sound like Penny Wynn in a moment. And I know. And the how and the why here is, you know, obviously what we'd like to know for sure. But as RMTs, it's good enough for us to say, okay, well, I know that when I do this, it does this. Now, what we have to do is we have to think from there, right? We have to have something that's simple and consistent as a way to explore that, because everyone's different. And this is one of the confounding factors in any research in this field, is the fact that you can take 10 people in a room and only 6 or 7 of them might respond the same way to the same force. The other 3 or 4 might be like, it didn't do anything the same. And all 3 or 4 of those might be completely different too. So we typically only have about 60% to 70% reliability with a lot of these tests. It seems to be a number that repeats a lot in our field. With regard to remote force transition, with regard to manual therapy, so back to the force transmission one. We can see decent evidence of what they're talking about. Do you remember your slump test? So the slump test is distinctly, according to the definition in this article, a fascial system test, because it's based on neurological tension and gliding of the neural sheaths.
Right.
Right? And so, I mean, a slump test is a valuable test, but it's also a valuable rehab exercise. If I do, okay, head here, legs here. If I straighten the legs, I've put the nervous system under tension. If I flex the head, nervous system under tension. If I do here to here, I'm staying relatively neutral. So I'm flossing the nerves back and forth. If I stay here, I'm tensioning the whole thing. And that is distinctly, according to this article's definition, a fascial test and exercise now. So we certainly do have things like that that are more mechanical in nature, but we can also look at local remote response. So instead of saying, oh, I stretched your hamstrings and now your C-spine moves better because of it, we can look at, okay, I worked with your Achilles tendon. I had you do some eccentric loads there, and the back of your knee feels less sore. Well, mechanically, there's a good possibility there. It's your freaking gastroc where it interdigitates with your hamstring muscles. Yay, science. But then there's, of course, neuromodulating. Manual therapy-wise, though, this does help with us a lot, not for the fascial reasons necessarily, but for the remote part, for the principle. And again, we have the principle. We can see the principle. We can test the principle. We just don't know the whys. But what we can do without needing the whys is to say, with you as a patient, Jennifer Fleming, if I treat your, I don't know, neck pain, we notice that your lateral epicondylitis reduces. Okay. God, this is another reason I wish Pets was here. This is exactly how Dan Pets treats. This is his entire paradigm.
What's affecting him?
He's hit and miss. He's probably like skiing in Gardenia now or something. But with regard to that, we can use that as a treatment approach for that individual. So say, you know that 3R thing I always harp at? Yeah, so say when I'm assessing range resistance and rate of motion in an individual, I find that they respond atypically I don't care about the how or why yet. I'd love to figure it out. If I can, I will. Or if I can, I want to. But what matters right now is I know that you as an individual respond like this. It may be atypical. It might give a clue as to why you're having a dysfunction as well, but it also gives us an avenue to explore for your rehab. And so if we read between the lines here in this article, as manual therapists, oh, well, by doing this and doing this, we affect C-spine range of motion. Okay, great. My takeaway as a massage therapist is, if I work on this person's legs, don't be shocked if I have other locations of efficacy. If I find that consistently works with them, then I'm going to include that for their potentially whiplash-associated disorders moving forward, or concussion symptoms. I might have a treatment plan that includes ripping your hamstrings out, because for you, I see such a consistent correlation where if I work on your hamstrings, your neck feels better. Much more so than anyone else I've seen. God, I really need to work with pets.
I was just going to say, a lot of times, a lot of my clients have a lot of knee, low back, hip pains, often associated with poor foot dynamics. So working on the feet, the ankles, looking at orthotics, all of a sudden these things end up affecting other areas. Just as you're saying, working on hamstrings could affect the neck. So I think this does, if you can deal with one area that is not functioning properly, it will affect other areas. And this again is where the fascia comes into, because it is all interconnected.
But is it fascia?
But, well, it not necessarily just fascia, but it could be just muscle alignments, like all of that. It's everything I find is interconnected. That song, my leg bone is connected to my hip bone.
Yeah.
So,
but let's use the example you brought up for this one, because it's a perfect example. You're bringing up a really good point. So, okay, let's say me slapping in a foot orthosis on, how old was he? 15-year-old male soccer player, bilateral foot orthoses for knee pain, low back pain. Athletic, no health history indicating a need for them necessarily, except for knee pain and lower back pain. Very active, very healthy lifestyle, very good diet, very good rest to activity ratio. He sleeps well, he wakes rested. We put a foot orthotic in. Why does he feel better?
Well, it could be one of two things. One, it could be the that extra support is allowing a better trying to find the right word, balance. The other is it could be all just what they're thinking, saying, oh, this is what's going to fix me, and so mind over matter. So I think.
So, sorry, I don't mean to cut you off.
No, go ahead.
So let's go to what the arches do. What do they do? What do the arches of your feet do for you walking? Just for you walking. What do they do?
Oh my gosh! Now you're testing.
It'll make sense in a sec.
Yeah. So the arches allow proper foot dynamics, proper weight distribution.
What do you mean by proper? Like if you have flat feet, is it improper now?
You know what? It depends on the person.
Right?
So I don't think there is one person. You can't compare the arch of one to another. You have to look at their own. So you look at eversion, inversion, all of that to see where the like how the arches are supporting the feet. You look at the symmetry of the leg, the knee, the hip. So you're looking at all of that.
Okay. Now,
but it all starts at the feet.
It sort of does, depending on the school of thought you're following, right?
Okay.
If you're following a biomechanistic school of thought with gravitational loading, then it starts at the feet.
Yeah.
And going to symmetry aside, we can look at Usain Bolt as your quintessential like flavor of the day right now for that example, because he's very asymmetrical in his gait.
Mm-hmm.
But he's also the fastest dude alive. I think he still is. I don't know if he still is, but he was.
Okay.
So he's a very asymmetrical gait, an asymmetrical stance, but he kills it. But we look at what our arches do. If we define their function like in gait, in stance, is to absorb the force of impact and to redirect it. If we make it as simple as what we know. So pronated, supinated, flat, or regular, or whatever, it's going to be, does your arch allow for transmission of force up the kinetic chain in such a way that the rest of the kinetic chain isn't at risk as your nervous system interprets it? And if your nervous system interprets it as being at risk, then we're looking at the potential for a pain output. Now, if I put the orthotic in there, all we know is I've changed the arch environment in such a way that the nervous system now says, cool. Is it because it's aligned up? It might be, it might not. Okay. And so when we're playing with this, we can use that as a perfect example as to, okay, going back to the article, instead of assuming alignment, let's look at what we do know, because the alignment has to make an assumption. The reason I know this one is because I fell for this myself when I was 16 with this bonehead chiropractor in Ancaster who, you have a stretched calcaneonavicular ligament and you're going to need orthotics for the rest of your life. And I know you're a student and that's expensive, but that's okay because I will give you a discount. I've got you covered. And so he gave me a discount from $500 to $300 per pair or $200 per pair because he's just such a great guy. Now, I mean, he was only making $105 per pair of orthotics, right? So he cut back significantly on his new yacht. But he still wanted me to be in orthotics for the rest of my life, 2 new pairs a year, because a stretched ligament based on him seeing me stand. When realistically, it's not the ligament that does the arch support. It's a part of it.
Yeah.
It's neuromuscular intervention, everything. We never tested whether I could have functional arches. We never tested whether or not there was a way to intervene alternatively. And is it the alignment?
Mm-hmm.
So with that soccer player I mentioned, we did a bunch of rehab on him, and he's out of his orthotics, and it was stupid that his chiropractor put him in those at I think he, like I said, I think he's like 15 or 14 or something. He's young, and he's super athletic.
Well, and that's one of the things too is, are people, professionals intervening too early?
It's not early, it's testing.
Well, okay.
So if you, for me as an example, for my arches right now,
yeah,
am I heavy enough that my arches cannot mechanically support that weight? Do I have a neurological disease that prevents me from using my arches in such a way as to support my weight to attenuate the force? Or is there a mechanical disease of some sort or injury of some sort, pathology of some sort like that, that prevents those arches from functioning normally? If the answer to all of those is no, then theoretically I don't need an orthotic.
Mm-hmm.
Explore elsewhere. If it comes down to, okay, we can't figure it out and putting an orthotic in helps, then we go with that, right?
Yeah.
So is it aligning it? Okay, well, let's put my foot into alignment. Let's windlass tension me. So I put my foot down, lift my big toe up. The arch lifts. And I say, now just put your toe down, lifting the arch there, and do a quarter squat. Does your knee go away? Or your knee pain go away? And then we have an alignment test, right? It still doesn't take into account nervous system adaptation, but it's an alignment test. And so when we're going back to this stuff, they're talking about remote changes and talking about it being mechanical. Might just be that your nervous system just said, well, fuck, I like that.
Mm-hmm.
I think that's novel enough that I'm not sure. And then we have to have a 10-day follow-up because 10 days was the course that we're going to see nervous adaptation, right? Like, not like CPG creation, but like, You know when you get used to something?
Yeah.
Yeah, like your nervous system is like, okay, I got this.
Yeah.
So over 10 days, we're going to have a good test as to whether it works. I would normally have a term for this. I swear to God.
That's okay. It's a Sunday morning.
But yeah, thank you. But your nervous system is going to say, okay, I like this or not. And so we can now follow up and say, okay, with those in, how's your knee pain been? Oh, it kind of came back, or it didn't. But we can also then say that's a good temporary effect. Now let's try to wean you off, right? We have a lot of options here without going to the mechanical. We have to include the mechanical, obviously. That would be crazy not to. But with them talking about, like with us going back to what are the interventions that we as massage therapists can do for this, we can take into account. Yeah, we take into account the alignment. And for axial loading down a joint, down a chain, alignment matters, because if I'm off axis, it's harder for me to push hard. That's just that simple. But for axial loading, if I'm used to being off axis, then it's fine. Like Dean Somerset did an article on when biomechanics go out the window, I think is the title of the article. And there's a Kenyan marathon runner. And oh my God, watching her run made me die a little inside. When she runs, her knees valgate on each step.
Okay.
A lot. It scared me. And she's been doing that for, I think, 30 or 40 years now. And she's won multiple marathons. She's won multiple Boston marathons. Like, she kills it. And she's like, I've been being told since I was 16 that my knees are going to dislocate or rupture, that I'm going to blow my ligaments. Well, I'm in my 50s at this point, and I kind of consider they owe me nothing. So if they blow at this point, great. And her biomechanics of her loading response are so off, but she has zero pain, and the woman's incredible. She's just a beast. She runs at distance better than I run at sprint for more than 10 seconds. It's ridiculous. And she's got no issues. Nothing that we can tell.
Well, and again, that's when you have to look at each person individually.
Yeah.
Well, right? So this runner, that works for her.
Mm-hmm.
If you try to mess with it, if you try to change it, whether it's through orthotics or biomechanical changes or whatever, she's not going to function as well. And she could end up blowing her knee. Because
we've intervened.
But because we've intervened. So you have to be careful what you add or take away from whatever you're doing with.
Exactly. So going back to the alignment changes, going back to using something like orthotics or checking alignment, what if we go back to that, to a more simple, I always use this 3R approach. I like the 3R thing because I find it simple.
So what was your 3R approach? It was range?
So
resistance?
Yeah. So okay. So I'm flexing my wrist forward. Yeah. I'm at approximately 90 degrees of flexion at the carpal region, right? So that's 90 degrees of range. And if we look at what plane I'm in, 90 degrees of range in a parasagittal plane in anatomical position, right?
Yep.
And so I have a range of motion with a vector, a direction of motion. And that would be my first R, my range R, measuring those out. Now, if I have pain to here, if I try to push back against it, but if I go here, I can push with no pain, that would speak to the resistance at different ranges. And then rate is the speed of movement to and or from a range, or resistance to, or the slowness of it. So if I'm going really quickly, I need to have explosive force each way. If I'm going really slowly, I need to have collateral stability each way to control. Yeah. And so if we break every discrete movement down and kind of not even measure everything, but it'd be nice to measure everything, but keep awareness of those things, we can say, okay, so for this person with these orthotics, at what range do you encounter pain in a squat versus not? If I load the squat heavier or lighter, does it change? Some people will have, like for me, I have pain in my right knee walking up and down stairs. I will not typically have pain, however, if I'm squatting 260 pounds.
Okay.
Weird, right?
Well,
If I
no, because you're using the muscles differently.
But if I do step-ups,
Yeah.
holding 2 dumbbells at 40 pounds apiece, no pain.
Okay.
Now we're getting weird. So
Now
if
we
I
are.
walk up the stair, I get pain in my right knee. And it's been like this.
Carry those 40-pound weights.
But you toss 80 pounds on me, and all of a sudden I'm like, oh, well, this is so much better. And I can actually step higher with less pain. I still don't get it. But it's an observation on me. And so what I can do is I can at least hack that observation and say, okay, I'm going to work out more. And now I don't have pain walking up and down the stairs as I've gotten used to that. And what was neat was it started at heavier, was pain-free, and then lighter and lighter and lighter got pain-free, to now the point of just carrying around my own bulk doesn't bother me.
Yeah.
Which sounds counterintuitive, but if we look at collateral stabilization, my nervous system is saying, oh shit, you're carrying more. I need to do more work. Whereas when I'm carrying my body weight, it might just be being more careless.
Yes.
That's what I was going to say.
Well, screw you too, Jen.
Well, no, I was just thinking about the whole, if you put more weight on with the dumbbells, now you can do it better. And I was like, well, maybe you're just using different structures. Your brain is like, oh, we need to or whatever, efficiently or what have you.
Well, maybe the end result has been that I've upped my movement intelligence. It did work within those 10-day cycles I'd mentioned. And I did do some documenting on gait assessment, things like that of it. Like I did some videos of myself and checked it. And it all kind of clicked with that. But again, if we're looking at, this all has to go back to this article, right? If we're looking at mechanical intervention, we can try to step back and say, okay, what can you actively control? And if we're talking about fascial transmission versus neuromuscular adaptation, we have a nice clear one. How long does it take for fascial adaptation to force on average? Do you guys know?
No.
At tendons, I know it's 4 months. For fascial sheets, I don't know. I don't know about the other stuff. I was hoping someone could fill in those blanks. But I know it's going to be longer than 10 days. And so if we see a person adapting rather quickly in those shorter mesocycles, we would be able to say as RMTs, okay, you're responding well to this. You're getting stronger like this. You're getting less pain like this. This is nervous system. This is not scar tissue at this point. Oh, it's taking us 6 months to load that differently? Okay, we're looking at plastic response. Like with tendinosis in lateral epicondylitis, your expected recovery is about 4 months, 5 months, if it's versus tendinitis. So at least we have something we can rule in or rule out with some critical thinking. And say, well, if this is responding quickly, it's got to be neuromodulation. Or hormonal. So, especially with women with cycling, that's a thing to take into account. I don't know too much about different pain tolerances, things in cycle, but I know in cycle, things can change a lot. Okay. Sorry if that was too tangential.
I don't know if it was too tangential, but it was a tangent. Which is fair. But I think the tangent is useful because it kind of speaks to one of the things we talked about in the very beginning, in that maybe in terms of strictly talking about fascia, this article is I don't know. I'm really hesitant to say useful. I'm starting to lean towards this article is not very useful. Certainly not as a standalone.
As a standalone, I agree with you. With context, I think it's great because it's given us some good discussion. It's left me with at least one big question I didn't realize I need to cover.
Yeah.
And what's your question?
Yeah.
Again, women's adaptation on oral contraceptives.
Yeah.
I deal in my clinic. I deal with basically primarily 2 types of patients on average: athletes and oh shit patients. The oh shit patients are like the referrals from other colleagues when they're like, oh shit, I don't know what to do with this. Yeah. And then the athletes are people who've heard about me, like, oh, I've heard you're good at figuring out puzzles. I have this problem when I lift. What's wrong with it, right? And like that's the vast majority of my clientele, at least right now, which means there's a big freaking hole in my reasoning that I didn't realize was there. Like a big one I need to patch.
Well, you know what? We're all finding things that I have 3 or 4 things here that I'm going to be looking into a little more deeply, just for my own personal information. But it'll be interesting to see, like, these articles, just how they open up different avenues of, oh, maybe I'll look into this area a bit more. You know, you see where your holes are.
So, I want to just kind of do a time check-in. It's 12:45.
Okay.
I mean, I'm sick, so I'm basically sitting on the couch all day. So time for me is irrelevant, but I want to see.
I'm going to be heading out in a few minutes.
Okay.
I do need to have some breakfast soon. I'm getting pretty hungry.
Okay. So then maybe we should try and wrap up at least what we've talked about a little bit. Do we want to, is there anything else that anybody wants to discuss? I mean, I feel like we could keep talking about the article, but, you know, time being.
One more question I had that I wasn't sure if any of you might have info on. It's just a question. I don't really have much in the way of thoughts on it yet. Page 5, left column, they mentioned stretching fascia. Let's see. Regardless of the underlying mechanism, fibrotic changes in the stretching of fascial tissues can promote resolution of inflammation both in vivo and in vitro.
And then the second half to that is manual therapy can prevent overuse, blah, blah, blah. Is that so?
Yeah, like I walked away from that with a big old question mark floating over my head.
Ditto. I personally felt like that was a bit of a leap. Because, like, I don't know, I would have to read number 71 and 72 in their
I'm literally looking it up right now.
Are you?
Yeah.
In order to see how they've arrived at that idea, because that is pretty relevant to us, right? In the work that we do, if stretching fascial tissues can promote resolution of inflammation, both in vivo and in vitro, and manual therapy can prevent overuse-induced fibrosis, that seems like that's something that we should really absolutely know. Because that feels like a really bold claim to me. Because there's always all this discussion about massage therapy as preventative. And is that true? Is that really real? Are we, you know, making shit up?
Like, looking at the abstract right now on that article, I'm immediately like, ugh.
Oh, like 71?
Yeah, we showed earlier that in rats with subcutaneous inflammation of the back. None of these, very few of these are going to be on people because of ethics. But so they induced inflammation by carrageenan injection, stretched them for 10 minutes twice daily, and at the end of 2 weeks after the injection, they noticed that there was reduced inflammation and improved pain. They hypothesized that stretching of connective tissue activates local pro-resolving mechanisms. It doesn't say anything about a control group. Well, at the end of 2 weeks after having an inflammatory response, I'll usually feel a lot better too.
Yeah.
And it doesn't say they're stretching fascia, which this says they're stretching fascia.
Well, and that was one of the things that I was kind of wondering about, is how can you be certain in, you know, an active environment where I am working with a specific patient, how can I be certain that what I am targeting in the movements I'm performing with somebody is fascia and that nothing else is participating? How do I turn off that person's nervous system? I mean, short of murdering them.
That reminds me, I want to do an experiment with pig's ears.
Pig's ears?
Pig's ears, yeah.
Okay.
Renata, where are you located?
I'm in Guelph.
Oh shit, that's not bad then. Okay.
Yeah.
And then Dawn, you're.
There's a lot of pigs here at the college, actually. So.
I know you guys have a great cadaver lab there too.
We do.
I know, I love it. But sorry, okay. And Dawn, you're located somewhere in a different time zone, right?
Yeah, I'm in Vancouver.
Oh, well, that doesn't help much then. You're a bit of a drive.
Yeah, it's a wee bit of a drive.
But yeah, I've been mulling over doing this for months, and this article kind of reminded me of it again, was going to a butcher and buying some pig's ears and then treating them, like quote unquote, treating them in different ways and see if we can get pairs of pig's ears. So if I have a left and right from the same pig, I leave one untreated and I do Graston style treatment on the other one. And then we hook each ear up to a clamp and pull until failure and see if there's a change. And then do the same with, say, like myofascial, do the same with rolling, do the same with shockwave, etc. And see if there's a change in tissue failure rate on the bilateral ears. So we would need a pair of ears from a pig for each, of course, test, or at least a pair of ears that are very dynamically and structurally similar, and then test the failure points on them left to right on each one to see if, oh, well, when I tested 10 pairs of ears, Graston ears, the Graston ear failed more quickly than the other. We have evidence that there's plastic change because the nervous system's out of the equation, right? This is just tissue. This is just dead tissue. But I Graston this ear for like 10 or 15 solid minutes or 20 minutes and scrape the shit out of it. And then we test each side and we say, okay, how much difference are we making here?
Are you using?
Yeah, the only problem I can see there is that you're not dealing with any kind of tissue perfusion.
That's the point, right? Take that all out of the equation and just talk about the mechanics of breaking down the tissue.
Yeah, although you would see
that fascia.
that rate would change significantly if your lymphatics are in action. You know, talking about an immune response, you're talking about a dead system that doesn't work. You'd have to do it in living tissue. So let's use politicians.
Well, that's the thing. I mean, this is the whole point is to take this to the simplest possible equation, right? So let's take out of the account all of the other, like all the dynamic processes, and go to the static, and say, okay.
Yeah, although the fascial system isn't static, that's the problem, and you're dealing with a system that's adaptive in real time.
I know, and this is to test a single concrete treatment's worth. So when you deal with someone who says, I'm breaking down connective tissue, this has nothing to do with it being dynamic. This is me saying, I'm scraping you and breaking down scar tissue. The claim to that means I have now changed the plastic environment in an acute concrete treatment. I don't want any lymphatic, any neurological, anything. I want to say, okay, if I do that treatment on dead tissue that can't recover, that can't respond, then I know whether or not that has the potential to damage the fascial tissue, assuming it's not cured meat.
So you're looking to see if you can
good like bacon,
mechanical impact. Strictly, nothing else. There's no neurological responding. There's no immune responding.
Well, these fascial people actually talk about that. That's one of their go-tos is we're unwinding the fascia, we're breaking down the fascia, we're realigning the fascia, things like that. And they talk about it as a static plastic entity when they talk like that.
Yeah.
They'll say, well, I'm digging my thumb in, and what I'm doing right now is I'm breaking down your scar tissue. Okay, cool. If you're breaking down scar tissue is a dead thing, so to speak. Fascia is a dead thing, so to speak. When it's in a live body, it's alive. But if it's in a live body or cadaver, it's still the same tissues, still the same cells. They might be dead, but we're just talking about structural integrity of them. Now, in terms of in a live body, of course, it obfuscates it more, but it obfuscates it in the wrong direction. We're trying to move to homeostasis. Unless we're taking a vitalist approach and saying, oh, well, you're just freeing up the innate ability to heal, which is exactly not what fascial therapists are talking about. We can say, okay, fine. Since your body is not fighting to recover from what I'm doing and not trying to heal from me potentially breaking things down, or prevent tissue trauma by changing position of the organelles and things like that, of the cells moving it around, we now know, okay, this is just the tissue. And that's kind of why I wanted to do it, was to test exactly that thing. Absent of all the other obfuscating factors, one simple factor. Okay, tissue integrity. Are we changing it? In one treatment.
But
one aggressive as hell treatment.
yeah. Well, the one thing that you would have probably an issue with is once a living organism is dead, that tissue starts to break down anyway.
That's why I'd want bilateral ears.
Yeah.
Because it doesn't matter if that tissue started to break down or not. If I have a control that's the same as the tested one.
Yeah. Yep. I'll talk to my butcher.
I would actually appreciate that. That's the reason I haven't done it. I've been mulling over doing this since like summer last year.
I'll see if he has any pig's ears.
Yeah, I can't remember. I was talking to a patient about the way I used to treat and what I used to think. And he was like, well, how would you test that? I was like, I don't know, probably with like pig's ears or something. I was like, holy shit, that would be feasible.
Yeah.
But
okay.
But going to this, they're talking about stretching fascial tissues in this thing. But the article they're referencing isn't talking about stretching fascial tissues at all. It just says stretching.
Yeah. Which
is, plastic and neurodynamic and immunological, all in nature.
Yeah.
And emotional. Fuck. Freak. Emotional. Sorry, I swore.
Nothing we're not used to yet. I'm going to have to head out. Lovely meeting all of you. And Jennifer, I'll look forward to seeing what you write up.
Yeah.
And look forward to the next one.
Yeah.
So have a good day, everyone.
Thanks, Renata. Nice to meet you.
Nice meeting you too. I didn't say hi at the AGM, so but.
Oh, you were there?
Yeah, I was.
Oh, cool.
Yeah.
That was scary for me. I've never been to one of those.
Scary. Actually, they're really good. I was hoping there was a question period, but I don't think anybody was willing to question anything that time. But quite often it's a lot more, people are a lot more excitable than they were this year for some reason.
This is a good toes wetting for me. If they were more excitable, I think it would have been more intimidating for me.
You know what? It's not intimidating. It's a very safe environment.
Yeah? Okay.
People are very good. I have never seen anyone, attack another colleague or whatever, verbally or whatever. So it's always good. You can leave with some good information. And the executive is so available. So it's quite nice. So if you're not a member of the RMTAO, as I tell all of my other colleagues, get your ass in gear and start.
Yeah, like what they offer is amazing. It's just, I've never gone to anything massage based at all, right? I just hide in a basement and study, basically.
Are you going to the conference June 1st and 2nd?
That's the one in Burlington, right?
No. This one will be, I believe, at the Marriott at the airport.
I'm sorry, I was like stereo, no.
Yeah. No, the Burlington one is the last weekend of September.
Yeah. Okay, I met, one of my colleagues introduced me a guy who does the Burlington one.
Yes.
To have me talk there, apparently. I didn't know there was a different
one. So this is the one put on by the RMTAO. It's the evidence-based conference or something. So if you go onto their website, I haven't seen registration for that yet.
Okay, I probably want to go to that.
Yeah, I haven't gone to that one yet, but it's always conflicted with my lymphedema recertification.
Oh, okay.
So, this year there's 2 weeks apart, so I think I can manage it because I can work my Saturdays in between those now.
Okay, yeah, like
but
this year.
But the conference in Burlington, it just depends on the year and who they have coming.
Yeah.
It's not run by the RMTAO.
Yeah, it's run by a dude who lives actually near Jen, apparently.
Yeah.
He lives in Hamilton, aroundabouts where Jen lives, I think.
I found when I first started going, like 20 years ago, that conference was amazing.
Yeah.
Then they moved it to St. Catharines, to Niagara Falls.
Yeah.
And they lost a lot of people coming to that. They actually coordinated it between the chiropractors and massage therapists.
Yeah.
I don't think it went over well. Burlington is a nice area to go to. It's really local for a lot of people, easy to get to. And the speakers are really good. They need to work on their vendors, though, that are coming.
Okay.
So the vendors were a lot better years ago, but hopefully it'll start improving.
Okay. Yeah, like I said, I'm kind of coming out of my shell this year, right? So I'm pretty sure I'm going to take Walt Fritz's chewing and swallowing disorders course.
Okay, yeah.
I got to look into the actual content because I've studied it a bunch on my own. So if it's just a review, it wouldn't be worth the $500, right?
Yeah.
But given that Walt's teaching it, I suspect there's going to be a lot of stuff I don't know. So
yeah. Well, and it's an opportunity to ask questions, right? So.
Well, that's the thing. He's already good with answering questions when I message him.
Okay.
So, yeah, it's just I chat with people. I just do it from the safety of not seeing them.
Okay.
Yeah, so I think I'll be going to that, and then I'm going to the one in Burlington, I think. So now that I know about this, I'll look into it as well.
Yeah.
The conference that I was telling you about, Rob, and I was saying you should apply to be a.
Oh, I thought it was the last one that I was at.
No, that was the AGM. This is a pain science conference that the RMTAO is putting on, and they did a call for.
Okay, that's the one that they had the thing to. No, that was for what?
They had a call for papers or whatever as well for that one.
Yeah, I submitted, but they'd already picked someone.
But
next time.
I'm glad you did.
Okay, gotta go. See you, everyone. Have a good day.
Renata, thank you so much.
Yep. Bye.
Bye. Yeah, I
guys, I'm
submitted
the boogie as well.
Okay.
See you later.
Have a great day, Don.